Good morning. If people can take their places, we'll proceed with the panel. Thank you. My name is Greg Stoddart, and I'm one of the people that Morris brought out of retirement to help with the conference and to be a co-editor of the book, An Undisciplined Economist, which is the flyer for which is in your packages. And it's been, Morris, a labor of love on both fronts, so thank you. It's a pleasure to be here and to chair our first panel, which has the title, Contemporary Canadian Health Policy Challenges. The format for the panel is that we will have 4 panelists, 2 before the mid-morning break and 2 after. Each speaker will have 20 minutes for their presentation, for her or his presentation, and up to 10 minutes for questions and discussion. As you've already seen in the program, this conference has what I would say is an all-star lineup of speakers, and our first 4 illustrate that all-star lineup very well. So I will introduce each just before their talk, and starting with Danielle Martin. Danielle is Vice President, Medical Affairs and Health Systems Solutions at Women's College Hospital in Toronto, and she's also a family physician in the Family Practice Center there. Also an assistant professor in the departments of Family and Community Medicine and Health Policy Management and Evaluation, and others at the University of Toronto. She's one of the founders of Canadian Doctors for Medicare, and she has defended Medicare on such disparate fronts as the CBC National News and the U.S. Senate. But that isn't to say that Medicare can't be improved, and she will be discussing one aspect of that today, the challenges of getting a national Pharmacare program. So please welcome Danielle.
Thanks so much, Greg. It really is a tremendous honor to help kick off this panel and to pay tribute to the giant on whose shoulders we all stand whenever we try to bring evidence and research together with common sense and courage, the courage to call it as we see it in Canadian healthcare. So I think I'm pretty sure that I speak for almost everyone who's going to be up here on the stage over the course of today and tomorrow when I say that we wouldn't be doing ourselves any favors and we wouldn't be honoring Bob Evans if we didn't try to take some risks in the conversation that we're going to be having. And so I'd like to begin when I was asked to speak about the contemporary policy challenge of Pharmacare by taking some risks myself. Therefore, I'm entitling my talk, Pharmacare, Getting Used to Disappointment. So what is the contemporary policy challenge of Pharmacare? I'm not going to spend very long on why we need Pharmacare, why it's a good idea. Where do I point this thing to advance my slides? Could someone advance me to the next slide, please? No, that's definitely not the next one. Uh-oh, you've seen it all. There we go. What's the challenge? I've got nothing left to say. What is the contemporary policy challenge with respect to Pharmacare? Well, I think, and as I've said and others have said before, part of the issue around Pharmacare is that it isn't a single policy challenge, just as it isn't a single policy solution. But some of the challenges that people mean when they talk about the challenge of Pharmacare are enumerated on this slide. The first is the challenge of extremely high costs. As I think everyone in this room knows, we do have prices that are 30% higher than the OECD average. And I am one of those people, Bob, who went back to school to learn a little bit about economics so I couldn't be deceived by economists. And one of the things I learned is that cost equals price times volume. And in Canada, of course, we have a problem with pharmaceutical costs, both on price and on volume. First, that our prices are too high, and secondly, that the volume of prescriptions being written and the volume of pills being eaten in this country is expanding exponentially, often with very little evidence of improved health. The second problem that we face with respect to pharmaceutical policy is the problem of equity. And I think everyone, again, here knows that we have an extremely, among the highest rates of cost-related non-adherence in the world, in the developed world, meaning that in Canada, 1 in every 5 households now reports that someone in their household is not filling a prescription or not taking their medicine as prescribed because of concerns about cost. And that is a shocking reality that those of us who are in clinical practice deal with every day. Even in a room as erudite as this, I'm sure everyone, if you were to ask around in your social services, in your social circles, would discover that it is not just a problem that's limited to the working poor. It, in fact, extends across all income lines in this country. The third policy challenge with respect to pharmaceuticals is that we have no incentive to quality. And as long as we have the fragmented and ridiculous system that we currently live with, we will continue to be in an environment where it is extremely hard to figure out whose job it is to deal with poor quality and poor appropriateness of prescribing in Canada, with the result that on the order of 1 in 4 Canadian seniors now takes a drug on the Beers list, a list of medications that should virtually never be prescribed to a person over the age of 65 because the risks outweigh the benefits. But of course, that's not it. We have a problem of inefficiency. We have a system that's built on a private insurance model in which the premiums going in do not remotely reflect the spending going out or the benefits paid back to clients or patients. And that ratio just continues to expand as the for-profit insurers take over more and more of the market. We then have a problem with avoidable complications. And I want to pause here because there's been a ton of attention paid, both in Canada and the US, not to mention elsewhere internationally, to the so-called high needs, high costs users of healthcare services. And yet we know that many of the people who are admitted, readmitted, and readmitted to hospital are landing back in our Canadian hospitals because of problems to do with pharmaceuticals. And then finally, I just want to say a word about clinical practice, because this isn't something that gets talked about a whole lot in Canadian health policy circles, but I've just completed, I didn't complete it, I worked with a group of tremendously intelligent family medicine residents who've just completed some research on the question of how the insane system of pharmaceutical coverage that we have in Canadian healthcare affects the way that we practice medicine in family practice. And what we are finding is that the amount of time and energy spent on workarounds in the current system is phenomenal. And the number of physicians who report not just giving out samples of drugs that they know are not really the drugs that their patient needs, but they hope might be better than nothing at all, not just saving the pills that the patient who got a side effect brought back so that you could hand it out back to the person who might need it next week, not just paying for the medication yourself, which is something that a large number of people are reporting, not just calling the pharmacist and spending 30 minutes on the phone in order to try to figure out whether there's some less expensive way to dispense these pills so that your patient will be able to take them, but all of those things, and all of them on a weekly basis. And so we find ourselves in a situation where our highest paid workers in the Canadian healthcare system are spending enormous amounts of time trying to work around a system that is fundamentally broken. So that's a big challenge. And it may actually be that part of the reason why we're having difficulty getting traction on fixing it is because we keep putting this panacea solution out there of Pharmacare as though there is a single solution or a single design that could address all of these factors. So what has that led to? Well, you know, the folks in the academic community have said that we have seen windows of opportunity open and close for Pharmacare over the course of contemporary Canadian history. And of course, so you know, this notion that practice makes practice, we keep seeing these windows of opportunity open and then we keep seeing them close again. And of course, a window of opportunity is something you can only really identify through the retrospectoscope. And it's not entirely clear which of these or which others that I don't include on the slide were actually true windows of opportunity. But it does lead us to ask the natural question, why? Why is it, given that we have all of the problems that I've just enumerated with respect to pharmaceutical policy, and that we have had at least some moments where it seemed as if some kind of change was going to be possible, why do we still find ourselves having this conversation again? Why do we have to get used to disappointment? And I'm going to put forward a number of explanations. None of these thoughts are my own. I'm simply trying to gather together what I hear people talk about, and I look forward in the Q&A to hearing what others view. So they're what I call the water cooler explanations. And people come up to me all the time because they know I'm out there talking about Pharmacare, and they say, well, I know why we don't have Pharmacare. We don't have it because the middle class already has insurance. So this is what I call the Obamacare phenomenon. People say it's really hard to do healthcare reform or insurance reform when the middle class is well insured through their employer-based health plans, and therefore the middle class doesn't care about this issue, and therefore a government elected based on a platform of improving things for the middle class is not going to care about this issue. Explanation 2. The political will problem. This is the argument that says politicians are in the pockets of industry, or politicians don't care, or politicians are afraid that it's going to be more expensive than we say it's going to be, and therefore what we lack is political will, which ends up being a code word for all kinds of other things. The third is what I call the chronic condition argument. I won't attribute it, but some of you might recognize it, which is that Canadians are too busy, blindly defending Medicare, and that if we would just get off our hobby horses about maintaining single-payer insurance for doctors and hospitals and diversify our funding pools a little bit, maybe we would be able to expand our coverage to include pharmaceuticals or more home care or more of something else. And so those are what I call the water cooler explanations. And the first sort of pins it on the public, the second pins it on politicians, the third pins it on industry. But it's not just water cooler folk that are analyzing this question. Of course, there's a rich academic literature, most notably Katie Booth's book, which I think probably many in the room have read, or at least her paper summarizing it, the work of Carolyn Toohey. And these kinds of more academic explanations look at the concept of how do ideas become entrenched. How do countries engage in paths that eventually trap them in a particular way of dealing with an issue? These are sort of political science explanations that talk about the ways in which more of the same yields more of the same, and therefore we end up always where we began. There are explanations that integrate, and others, and including myself, have tried to use John Kingdon's policy windows theory, windows of opportunity theory, to talk about how it is that at any given moment, the definition of the problem, the political stream, and the solution stream might or might not kind of come together, and what's the role of an individual person, a Monique Bégin, if you will, of kind of taking that opportunity and heaving it through the window. So those are explanations that try to integrate many of the factors that I've named. And then there are just the explanations that make a whole lot of sense to everyone, such as this one. Every dollar spent in healthcare is a dollar of someone's income, spoken by a very intelligent person we might be familiar with. So ultimately, these are all, none of these explanations are right and none of them are wrong. They're just different ways of trying to understand how it is that we've gotten so stuck. And although I think they do all resonate, certainly they all resonate with me, I'm sure they probably resonate with many of you, and you could probably name 5 more explanations, somehow, even though there are so many of them, they feel unsatisfactory. And I guess I'd like to spend a little bit of time trying to unpack why I think that is, and I'll be curious to hear the views of others. To me, it's because, in part, all of these explanations can provide some kind of retrospective analysis of how we've landed here, but none of them point to the solution. None of them unlocks what it is then we need to do, what force it is that needs to be applied, in what location, in order to actually change the channel on this conversation that we've now been having in Canadian healthcare for 4 or 5 decades. And also, I would say, at least for myself, part of the reason why I feel uncomfortable with all of these explanations is because all of them very conveniently pin the responsibility for this problem on somebody else. None of them pins the problem on us as a community of researchers, as a community of clinicians, as a community of advocates, either for, I didn't push the black button, I swear, okay. All of them, all of whom are participating somehow, we're all participating in whatever this rut is that we've dug ourselves into, and therefore, they're sort of convenient opportunities to point the finger elsewhere, both for the problem and the solution. And I'm reminded of the literature around the Choosing Wisely campaign, which many of you may be familiar with, is a campaign that I'm a big endorser of, I really believe in, that's aimed at reducing unnecessary, inappropriate, harmful, and wasteful healthcare, both in, well, not just in Canada and the US, but internationally now. I think 17 countries have signed on to Choosing Wisely. Choosing Wisely, for those who don't know, is a campaign in which medical societies have been coming up with lists of things that you shouldn't do in healthcare because they cause more harm than good. And amazingly, everyone seems to come up with lists of things that will reduce somebody else's income and not their own. It's shocking, right? So that the orthopods say we shouldn't do x-rays about, for this problem or the other, or CT scans, which would lower the income of the radiologist, but the radiologists say, et cetera, et cetera. So the point is that my sum total analysis of why we seem to be content to get used to disappointment on Pharmacare is because we continue to find analyses and look for solutions that pin the responsibility on someone other than ourselves. So I look at the next few years with this federal government that I do believe is committed to the principles of the Canada Health Act, but a government that did not commit in its platform to do really anything other than try to potentially lower prices when it comes to pharmaceutical policy. And this is where I see myself. I see myself in the Kubler-Ross grief cycle, trying to navigate my way through, the various stages of grief that we all are quite familiar with. And so I want to give you a sense of where, in my own introspection, how I see these stages playing out with respect to my own disappointment and where I hope that they will lead me as an advocate. So the first is denial. Well, they didn't say it in the platform, but they'll put it in the health accord. Right, so as soon as the premiers and the prime minister sit down at a table, maybe we'll come up with something that wasn't already promised, even though we've already got a deficit we've already got a projected deficit much larger than we anticipated in the platform. That's what I would call denial, and it moves straight to the I can't believe they didn't put it in the health accord response, which I would label anger and rage. Usually anger, at the lack of political will or the influence of industry or any of the other factors that I've named. Which is not to say that those things are not factors. Of course they are, but they lead to this highly predictable response among those of us who are trying to push for change in this area. Then we get to, well, I guess we lost our window of opportunity again. And it's going to be 3 more generations before there's another window of opportunity, and I guess it's just going to be more of the same, followed immediately by, but maybe they'll do catastrophic coverage, or maybe we'll see some improvement through the PCPA of prices that will allow us to moderately improve coverage or something along those lines. And then we finally get to acceptance, which is where I'm trying to push myself. I'm trying to personally push myself through these stages as quickly as possible in order to get to the final stage of acceptance, which is where I think we can all be most useful in this conversation about pharmaceuticals in Canada, which is basically, okay, what's next? So this is a fight on contested ground. I don't think that that's any surprise to anyone in this room. It's a fight about values, it's a fight about evidence, it's a fight about principles. It's also a fight about actual people who need actual health care and aren't getting it in this country. And so I don't shy away from calling it a fight. I do believe that that's what it is. And any good battle requires a good defense and a good offense. And given the crowd that we're in today, I do think that we need to think about what are the roles of researchers, what are the roles of advocates, and we shouldn't be ashamed or afraid to call ourselves advocates, and what are the roles of policymakers in trying to play both defense and offense on this incredibly important file. So I'm going to say a little bit about this. This is my first crack at this analysis, and I'll be interested in the views of the room. The first thing that I think we need to do on defense is to defend the brand. I think that the worst possible outcome that we could end up with over the next number of years in Canada is some, tiny slice of improvement in one of the areas that I have spoken about, and that it gets called Pharmacare. because that really will close the window of opportunity. So let us defend the brand of what it is, that totally unattainable panacea solution that will address every single one of the policy challenges I outlined. Let us defend that brand and keep our elbows out around it. We can still work for improvement in the area of coverage, in the area of pricing, in the area of bulk purchasing, in the area of evidence-based formularies, et cetera, et cetera. We can work with policymakers and anyone else who wants to see improvements in those areas, but we cannot allow those things to be called pharmacare. And I think that that's critically important. The second piece of defense that we need to play, and I sort of have covered the making interim inadequate solutions uncomfortable, is to continue to expose interest. And I do think this is the role not only of advocates, but actually the role of researchers as well, which links to the notion of matching the research to the discourse. We cannot leave the exposure of the very significant interest in this debate solely to people who are perceived as advocates in it for promoting conspiracy theories. We actually need the cold, hard data to bring forward in order for people to understand that when Bob Evans says every dollar is a dollar of someone's income, you can actually follow the money and trace where it's going. And I think that that's critically important. Otherwise, those of us who are trying to do the work of getting in front of the microphone, it's too easy to write off the messages that are being brought forward. And then, of course, in order to match the defense, we need a good offense, which means that we're going to need to enlist some groups that haven't heretofore been very active in the debate about pharmaceutical policy in Canada. And those are corporate champions. We now know and have multiple estimates of the size of relief that would come to the corporate sector were we to actually implement universal public pharmaceutical insurance in Canada. Why are we not hearing the captains of industry shouting from the rooftops, or at least in the back halls of the House of Commons, demanding that this relief be implemented immediately? We need to do a better job of enlisting clinicians. I must say that this small qualitative research project that we've engaged in, talking to family doctors about how the lack of universal pharmaceutical insurance affects the practice of medicine in Canada, has cemented for me the ways in which we have yet to tap the narrative power of clinicians in this debate. And then, of course, there are Canadians who can match those stories 10,000-fold. That's the integrating premise of all of this, of course, though, is that we need to tell the truth. We need to have a conversation in which the research that we put out there and the advocacy that we do is aimed squarely at unmasking the impacts of the inequity, the high costs of the inequity, and the human costs of the inequity on Canadians. And I think there is no better person to model that work after than the great Bob Evans himself. Thank you.
Okay, we have, I guess, about 10 minutes, up to 10 minutes for discussion and questions. While people are formulating them and coming to the microphones, I'll just make a couple of comments. Michael, go ahead.
Thank you very much, Danielle. That was really interesting. I just say that when I do policy analysis, so I'll apologize to Jonathan, who I sort of cut my teeth with if I'm not doing this correctly, but I tend to go, first of all, to the formal decision-making system, look at what the laws are, et cetera, because that often provides the first explanation. I'm not just trying to cuddle up to Colleen, who's the next speaker on this, but we've got a real problem with our Constitution. It's partly the Constitution, and then it's also the way it's interpreted. So in the United States, with very similar Constitution around this, the U.S. is deeply involved in healthcare and, for that matter, K-12 education. And both Supreme Courts in 95 said the federal government can spend their money as they wish. However, in 96, in the speech from the throne, the federal government, in response to the Quebec referendum, declared that no similar program like Medicare would ever be implemented without the full agreement of the provinces. So it seems to me that's everything else you said is true, but I sort of involved seeing things a bit in the back end of the accord negotiations these days, it seems to me that that is the first barrier, and it's immovable, and we can't get beyond that. And then we can do things around the edges like bulk buying. The federal government can share its information with the provinces that they only have. But it looks like that's the barrier we can't get beyond to even deal with the other barriers. So I'd appreciate your comments on whether, in fact, you think the constitutional barrier is real, and in particular the 96 speech from the throne.
Thanks, Michael. So I had the privilege of attending a meeting that involved 8 of Canada's provincial health ministers. I think that this so-called barrier is, I'd be careful how I phrase this, I do not think that this is nearly the barrier that it seems to be perhaps in the interest of the federal government to portray it to be. I actually think that we have quite a few ministers of health and premiers who are not just on board but openly advocating for solutions on this file that involve the federal government. We have a swing vote, and then we have a couple of premiers who are going to need to be yanked along. And, isn't that the fun of federal, provincial, territorial politics in Canada? I don't actually necessarily think that we need to have something called, capital N national, capital P Pharmacare to achieve our policy objectives. I think there are, and Colleen and I have been talking about this. I know she's thought about it much more than I have. There are many ways in which we could achieve the price savings, the appropriateness and quality goals, and the goal of universal public coverage without necessarily having to, set fire to the Constitution. And it may be actually that there are ways in which the provinces could engage in that, in those solutions very differently than I think we have traditionally conceived of it. I don't really care whether it's a federal program, whether they want to call it a pan-Canadian program, whether we want to, everybody wants to sign for Ontario to be the province that does the purchasing and BC to be the province that writes the formulary and, the Northwest Territories to be the province that does the quality and appropriateness stuff. I don't care. I don't think it matters, actually. What we need is for everyone to sign on, and what we need is for the federal government to play its convening role, to bring those folks to the table and to put enough financial skin in the game to make it clear that to not participate makes life difficult. And I actually think that it is entirely possible to do that without having to kind of stick the federal flag in the middle of the Pharmacare cake. That's my view.
Okay, the first question was from Michael Rackless. So could I just ask you to identify yourself before the question? Thank you.
Sure. Robin Tamlin from McGill University. Thank you, Danielle, for a very inspiring talk. I just wanted to ask you about a few things, but I do want to congratulate you on using Kubler-Ross in a new way that I've never seen before for policymakers.
This is just psychotherapy for me, really.
Yeah, I can get it. So I find this file really fascinating because some of the jurisdiction is at the federal level in terms of approving drugs and setting prices and in patent protection. And the rest of it's all at the provincial level. So I think, in part, that's probably a struggle of trying to do something nationally. But I was surprised he actually didn't mention Quebec, because Quebec a decade ago actually did institute national pharmacare for Quebec as a requirement, legal requirement. And yet you didn't talk about it. And if we look back in Canadian history, it was Saskatchewan that really started Medicare, and then it kind of flourished as a model in the other provinces. So clearly something has inhibited this sort of flourishing activity. And I just wondered if you just reflect a little bit on that. Like, why is it? Is this not a model that will work elsewhere? Or
yes, thank you. Thanks, Robin, for the question. So I think that if we are to look to Quebec on the Pharmacare file, it provides us a tremendous example of what we should never, ever do anywhere else in the country on this file. And I'll explain to you why. What Quebec effectively did, and they call it national pharmacare, but it isn't, this is actually a great example of how do we reappropriate that word, because what Quebec did actually is not remotely Pharmacare. What Quebec effectively did was institute an employer mandate and an individual mandate. I'm looking at Ted Marmer now because it's going to sound awfully familiar to him. An employer mandate and an individual mandate. They set some rules about who could and couldn't be rejected by the private insurance companies. They left all the employer-based private insurance intact. They required people who are, consultants or self-employed over a certain amount of income to purchase their own private insurance. Sounding familiar? And then they expanded the public programs to catch those people who fall through the cracks. And what has ended up happening is they now officially have, and it's hard to do this in Canada, the most expensive and least equitable situation virtually of any province in the nation. And the reason for that is because they've created a perverse economy in which when people become uninsurable in the private insurance, those people immediately fall into the public insurance plans, the people who are most difficult and most expensive to insure. The public plans have no real leverage for negotiating prices because they don't control the market, so they don't have any of the, if you look at the successful examples of bringing prices down, it's always when you can purchase, in bulk across the entirety of the sector. They haven't been able to do that, and it's become so expensive that they then had to increase the co-pays. And so what happens is actually you get people who are less able to purchase their drugs because the co-pays keep going up and up. And so, I'm blanking now on the researchers who engaged in this work, but for all I know, they might be in the room. So was that your paper? So I actually think that it is the worst. It's the worst possible example. As long as we follow examples of systems in which the private insurance remains untouched, and we view the role of the public sector as plugging the holes, I think we're going to end up with a highly expensive model. And maybe Ted can leap up to the microphone and talk a little bit about about what the international experience is. Maybe you can crawl slowly to the microphone.
Ted's going to have his chance
Ted's
later.
An international squash champion. I don't buy it for a second. Anyway, so that's my view. I know that analysis has been done on that, and to me, that's not Pharmacare, and I think that we do a disservice to the policy objectives when we call it that. But I'm happy to be, contradicted and engage in some healthy debate around that.
Okay, thanks, Danny. We have time for one more question from the left side over here.
Hi, my name is Rita McCracken. I'm a family doctor, and I'm doing a PhD at UBC about polypharmacy and frail elders. And you mentioned a couple of times the issues associated with overprescribing, and I really struggle with what the biggest harm or crime that my patients face, whether it's not being able to afford a medication that they actually need versus them thinking that they need to somehow divert their very limited income towards a drug that they don't need. Some of the new diabetes medications are great examples where we have basically no evidence that they are providing any long-term benefits at all. And I'm wondering if you could just speak a little bit about that.
Thank you for the question. It's obviously a critically important issue, and that's why I listed on my list of policy challenges. My view, providing universal public insurance for drugs is not going to address the appropriateness and quality issue. So the only thing that is going to address the appropriateness and quality issue is, there are many things that could. Certainly, there are ways in which one could design, I could imagine, and others have imagined, there are ways in which one could design a universal public insurance plan that would at least create the infrastructure to tackle this question. The problem is, and I don't mean to keep coming back to this private insurance thing, but I must say it is hard not to, right? When we effectively have 40% of the population covered by completely open formulary plans, where literally anything I write on a prescription will be filled, no questions asked, it is really difficult to engage in quality improvement and appropriateness in prescribing. So what are the things that we know work? None of them work, none of them work with a stroke of a pen, but the things that we know work for improving appropriateness, having an evidence-based formulary, because the formulary actually does guide prescribing, and that's a critically important component of a Pharmacare program. Academic detailing, so kicking the drug reps out of doctors' offices and replacing them with people who are actually paid to educate physicians and other prescribers on the evidence for the prescriptions that they write. Electronic prescribing, which reduces the likelihood that I or you prescribe something that interacts with another thing that the person is on or that they're allergic to, or that's more expensive and no more effective. And you combine that with, there are lots of other IT